Yeah, yes. Okay, so we will move to workshop 3. Workshop title is Liver Cirrhosis, Fibrosis, and its complications, NASH and NAFLD. So this session is organized by me, Yoichi Yasa, Ehime University, and Kenichi Ikejima, Juntendo University, and Shuji Terai, Niigata University. So now as you know, in Japan, etiology of the liver cirrhosis is now a major cause of alcohol and NASH. Rather than viral hepatitis. So we are discussing and please talk in this session. So now move to the first slide. So first title is the difference of branched chain amino acids tyrosine ratio (BTR) among chronic liver disease comparing to healthy adult. This is from the Dr. A.G. Kakazu, please.
Dear Chairman, member, and guest, thank you, Dr. Ueno, giving me the opportunity to talk about my research today. So this slide shows the COI. So I will explain the background. An imbalance of plasma-free amino acid PFAs gradually occur as chronic liver disease progression. However, the differences among etiology are still unclear. It is known that even in healthy adults, the level of PFAs are different as gender, age, and BMI. On the other hand, BCA tyrosine ratio (BTR) is often used to evaluate reserve capacity of liver and useful for timing of BCA supplementation. However, the reference range of BTR is wide and not divided by gender, age, and BMI. So this study's aim is to elucidate imbalance of PFA in patients with CLD according to disease progression and decrease timing of BTR in disease progression compared to healthy adults. This slide shows the method. We enrolled the data general adults from Talk Medical Megabank organization and the data of chronic liver disease from 4 hospitals. And we extracted healthy adults from the data general adults according to the following exclusion criteria referred to the Japan Society of Ningen-Doc. And we extracted the data chronic liver disease by the following exclusion criteria. And PFAs were compared between healthy adult and patients according to modified RB score after propensity score matching. From this slide, I show the results. The first slide is patient characteristics. So we divided the patient to 7 etiologies. So I confirmed the patient with HCV is older than other etiologies. So in this presentation, we focused on the HCV and MASLD and alcoholic liver disease because these etiologies, the patient of hepatocellular carcinoma is dominant. So this slide shows the change of PFAs according to the disease progression in total CLDs. So this figure shows in horizontal axis is 22 kind of amino acid, and by vertical axis is the fold change versus modified RB grade 1. So right side amino acid is increased, and the left side amino acid decreasing according to the modified RB grade. So we confirmed the BCAA is decreased. And aromatic amino acid tyrosine is increasing according to the disease progression. So BTR is BCA tyrosine ratio is clearly decreasing the disease progression. So this slide shows the BTR is lower in the patient with HCC than in patient without HCC patient. Regardless the modified RB grade, except modified grade 3. So on the other hand, this slide shows the data of healthy adult. The BTR is low in female and elder people, or even in healthy adult. And BCA and tyrosine also increasing by BMI. However, the ratio is not changed by the BMI. Actually, from this slide, I will show the results after propensity score matching. This slide shows the patient with HCV. So these three parameters is almost equal between the two HCV and healthy. So in patient with HCV, BTR is decreased at modified RB2A. So after 2A, gradually decrease BTR. And then the next slide is in patient with MASLD. So MASLD also equal or between MASLD and not healthy. So expectedly, the level of BTR is higher in MASLD at early modified grade, modified RB grade. And until that level will keep at modified RB2A. However, after 2B, even in MASLD, BTR is rapidly decreased. So this slide is a patient with alcoholic liver disease. So this result is very reasonable, I think, because in patient with alcoholic liver disease, BTR is decreasing at early stage modified RB grade 1. So gradually decrease after modified grade 1. So the reason of this result, I think the alcoholic liver disease patients often have malnutrition due to alcohol abuse. So the summary, BTR decrease timing. So modified RB grade 1 is alcohol, 2A is HCV, and 2B MASLD. Other etiology we can show by time limitation. So next, we focus the parameters of BTR and modified RB grade. So because BTR is composed BCA and tyrosine, and modified RB grade is composed of albumin and total bilirubin. So this figure shows the right upper value is the correlation value, and the left lower figure is the actual dot plot. So we can confirm the significant positive correlation between BCA and albumin, not total bilirubin. So I will show the actual correlation between BCA and albumin to etiology, HCV, and MASLD. So there are significantly positive correlation in both two etiology. Interestingly, the value of correlation value is higher in MASLD than HCV patients. So the level of BCA is even in MASLD decreasing accompanied with hyperalbuminemia. So this slide is last slide summary. Various PFA are changed according to disease progression in CLD. BTR is lower in patients with HCC than in patients without HCC. The evaluation of liver dysfunction using BTR will be overestimated for elder female patients because BTR is low in elder and female, even healthy adults. So we have to pay attention to the evaluation of BTR in PBC or AIH patient. So last point is BCL level may be severely decreased in muscle, even in muscle D with hypoalbuminemia. Thank you for your attention.
Thank you very much. So now open discussion. So it is very interesting. So also you indicated the difference between the ALD and the MASLD. So what is the difference, or what is the cause of the difference?
Yes. Generally, muscle D patient is very obesity, and the alcoholic liver disease is very often have malnutrition, and so body weight is very different between two etiology. So this is cause.
So difference between the male and the female, is that the same result, same reason?
Yes, partially, yes, same. But other factor is also, I think, between male and female.
Okay. Do you identify the some calculated factor of the adjusted difference?
Yes, yes, very important point. But actually, I can't each parameter matching, so we cannot the analysis. We next to the do.
Okay, thank you. Any other questions? Okay, thank you very much.
Thank you.
Okay, then we'd like to move on to the next presentation. The second presentation this session is Agile 3 plus and Agile 4. Non-invasive tests for liver fibrosis are excellent formula to predict liver-related events in non-alcoholic fatty liver disease. The presenter is Dr. Koichi Miura from Jichi Medical University. Dr. Miura, please.
Thank you, Chairperson. Hi, good afternoon, ladies and gentlemen. It's my pleasure to present our data in the present conference. These are our co-author and the COI. First, I'd like to talk about the background of the present study. As shown here, there is a good correlation between liver fibrosis determined by liver biopsy and liver-related events. However, it is difficult to perform liver biopsy for all patients because liver biopsy is costly, may have some iatrogenic complication, and inter-observer variability. Just use of non-invasive tests is expanding. So among non-invasive tests, Agile score is a combination of liver stiffness measurement by a FibroScan and these clinical data. There are two Agile scores, Agile 3 plus and Agile 4. Agile 3 plus is a formula to suspect F3 stage and more liver fibrosis. And Agile 4 is a formula to suspect F4 stage. So recently, Dr. Oida at Saga University Hospital reported there is a good correlation between liver fibrosis stages determined by liver biopsy and Agile score. Just Agile score is an alternative tool for liver biopsy. So we have previously reported non-invasive test to identify the patient with this liver-related event in a cross-section study. So red line is a border of rule-in and intermediate zone, and the blue line shows the intermediate zone and rule out. So among these non-invasive tests, FIB4 index is a good formula to identify the patient with liver-related event. However, there are many patients who are in intermediate zone. So FAST score was a good formula to identify the patient at risk NASH, but it is difficult to identify the patient with liver-related events. So Agile 3 plus is a good formula to identify a patient with this liver-related event, and Agile4 is good for to identify varices. So in a previous study, there were a couple of limitations, including a single center study, a cross-sectional study, and diagnosis of fatty liver was made by ultrasonography. So we conducted a multi-center cohort study to assess the Agile score to predict the liver-related events in patients with biopsy-proven NAFLD. So in the present study, a total of 463 patients were enrolled. Then 60 patients were excluded as following reason. Finally, we analyzed 403 patients. Among these patients, liver-related events were 11, as shown here. So this slide shows the characteristics of patients. The median age was 60 years old, and about 40% were male. In liver fibrosis stage, 14.6% were F3 stage, and 2% were F4 stage. So we investigate the association between Agile score and liver fibrosis in the present study. Both Agile 3 plus and Agile 4 showed high AUROC. In addition, Agile scores showed was a separate increase as liver fibrosis progressed. Then we draw the Kaplan-Meier curve of the instance of liver-related event and HCC. Patients with F3 to F4 showed significantly high instance of liver-related events and HCC compared with F02. Then we compared Agile rule-in and Agile rule-out and intermediate zone. As shown here, both Agile score showed a beautiful stepladder curve, like here. Then we investigate the distribution of Agile score in each fibrosis stages. A red line shows a border of rule-in and intermediate zone, and blue line is a border of intermediate zone and rule-out. Please look at the yellow box. A patient with advanced fibrosis stage, most of the patients with advanced liver stage were included in the Agile 3 plus rule-in, and all patients with stage 4 liver fibrosis were included Agile 4 rule-in. In contrast, in patients with stage 1 and stage 2, the Agile 3 score showed wide range. Also, a patient with stage 2 and stage showed a wide range of Agile 4 score. So please look at the green box. So there are only one patient who were Agile 3 rule-out, but fibrosis stage was F3. In addition, there were no patients who were Agile rule-out, but liver fibrosis was stage 4. Please look at the purple box. There are 30 number of patients who are Agile 3 rule-in, but liver fibrosis stage was stage 1 or stage 2, and Agile 4 rule-in, but liver fibrosis stage was 2 or 3. How do we manage this patient? Say goodbye, or it's time to start screening for liver-related events? So this slide shows the instance of liver-related events and HCC developed from F0 to F2 group. So instance of liver-related events and HCC, the Agile score rule-in showed a beautiful stepladder curve as shown here. So this is a list of liver-related events developed from F02. Most of these patients were Agile 3 plus Luluin and Agile 4 Luluin. In addition, there are 3 patients who developed a liver event within 2 years from the first examination of Agile scores. So from these results, Agile scores are a good tool to predict liver-related events. So this data are in accordance with this paper published previously. From this data, we consider Agile scores are better than liver biopsy for prediction of liver-related events. So we propose Agile 3 plus Luluin is a time of recommendation for screening of liver-related event, and Agile 4 Luluin is a must examination time. In conclusion, Agile 3 Plus and Agile 4 scores are excellent non-invasive tests for predicting liver-related events in patients with NAFLD, possibly without histological assessment. Thank you for your attention.
Thank you, Dr. Miura, for nice presentation. Now, the non-invasive test is very important for evaluating liver disease, and he showed nicely about the prediction of outcome by the Agile 3 plus and Agile 4. Now, this interesting paper is open for discussion. Any question, comments? Dr. Kong.
Thank you very much for your nice talk. I'm Kong from Untitled University, and I'd like to know whether this Agile score is useful to evaluate the efficacy of treatment of NAFLD.
That's an interesting question. So we have now don't have such a data, but in the future we are expanding our research, and we will show to answer to your question in the future.
Thank you very much.
Yeah, I have one question. So we are now familiar with using the FAST score, but you indicated the data Agile score has some advantage rather than the FAST score. So why they have advantages?
Yeah, so FAST score includes CAP, fatty liver score. So that decrease the chance to identify the patient with liver event. In Agile scores, they don't have CAP, liver fatty liver score. So that's the reason Agile score can identify the patient with liver-related events.
Okay, for liver events, so CAP is not good.
Not good.
Okay.
Okay, and now that NAFLD is renamed to MASLD, and also that there are a wide range of steatotic liver disease focused. So how do you think that can we evaluate the other type of steatotic liver disease, for example, MetLD or LD, using this parameter?
Yeah, so when we started this project, we just collected NAFLD only. So now we are expanding the patient with ALD. So in the near future, we will show the data of Agile scores, whether we can use this scoring system in ALD.
Maybe the considerable proportion of patient may be the MetLD, a new criteria. So that probably we should study on those population.
Thank you for your advice.
Okay, now it's time, and thank you very much, Dr. Miura, for a nice presentation. And now we'd like to move on to the third presentation of this session. Impact of liver fibrosis severity on oncological prognosis in hepatocellular carcinoma. One-to-one individual case matched analysis by Dr. Koya Yasukawa from the Division of Gastroenterological Hepatobiliary Pancreatic Transplantation and Pediatric Surgery from Shinshu University School of Medicine. And Dr. Yasukawa, please.
Thank you very much. So I will talk about the relationship between the liver fibrosis and oncological prognosis today. This is a COI. So in introduction, for hepatocellular carcinoma recurrent after curative resection has been reported that there are two unique patterns. One is recurrence derived from remnant micrometastasis, which means at the time of surgery, micrometastases were present from the beginning, which gradually grew and were considered recurrent. And two is that de novo recurrence arising owing to carcinogenic potential in the liver injury, such as viral infection. So Sasaki reported that recurrence rate of HCC is significantly higher in patients with liver cirrhosis than in patients with normal liver. So in the clinical question, so in Japanese, liver fibrosis stage was detected by new Inuyama criteria. Fibrosis 0 to 3 was associated with poor oncological prognosis. So this study is to investigate the cancer-specific consequences in precisely staged patients with hepatic fibrosis, and to evaluate the impact of fibrosis on recurrence in the entire cohort. The clinical pathological characteristics of the F1, F2, and F3 groups were compared with those of the F0 and F4 groups to analyze whether the degree of fibrosis was linked to cancer-specific outcomes. So each resection specimen underwent comprehensive evaluation for hematocystine and Elgin stained, and other Mallory stained slides, a minimum of 2 slides per case for both staining methods. From non-tumor regions to establish the fibrosis score and fibrosis score according to the new Inuyama criteria. A total of 524 patients were included in this study, and recurrence-free survival was compared to according to fibrosis stage, and a multivariate analysis for RFS was conducted. Furthermore, for one-to-one individual case matched analysis, which was conducted using R statistical software and OptoMatch package, normal liver compared to F1 to 3, and F1 to 3 compared to F4. Analysis of the recurrence rate and location following resection. Now I'll show you results. So this table shows the clinical characteristics for entire cohort. This p-value means comparison between F0 and F1 to 3, F1 to 3 and F4. The FIB4 index increased with fibrosis stage, while the tumor marker PIVCA2 decreased with fibrosis stage. Tumor size also decreased with fibrosis. This should be interpreted with caution, since the presence of fibrosis increases the probability of follow-up at the hospital, which may lead to a bias in favor of early diagnosis. Next, this figure shows RFS according to each fibrosis stage. There was a trend toward poor prognosis as fibrosis increased, and further stratification showed that F4 had a significantly poorer prognosis than F1 to 3, and F1 to 3 had a significantly poorer prognosis than F0. So multivariate analysis shows that age, high tumor marker, multiple tumor number, big tumor size, total vein invasion, hepatic vein invasion, partial resection, and fibrosis stage was independent poor prognosis factors. Furthermore, prognosis was poor in all fibrosis stages compared to F0. From here, the analysis was performed with a case matching cohort. This table shows matched cohort clinical characteristics. The values were generally consistent except for the FIB4 index and the ICG 15-minute value. This figure shows RFS and disease-specific survival for F0 and F1 to 3. For both analyses, F1 to 3 had a significantly poorer prognosis than F0. Similarly, F4 had a significantly poorer prognosis than F1 to 3 in RFS and disease-specific survival. This table shows that recurrence pattern according to each fibrosis stage. During the follow-up period, the total tumor recurrence rate was significantly higher in the F1 to 3 group than F0, and F4 group than the F1 to 3 group. No significant difference were observed in other factors such as size of recurrent tumor, multiplicity, and location of recurrence between the F0 and F1 to 3. Although the recurrent tumor size was similar, the proportion of patients with multiple recurrence tumor was greater in the F4 group than the F1 to 3 group. The recurrence rate by site differs significantly between the F4 and F1 to 3 groups. For recurrence in the same segment, unilaterally hemiliver ipsilateral lobe, contralateral lobe, and bilateral lobes. Lastly, this figure shows cumulative recurrent hazard risk. The cumulative recurrence risk in F1 to 3 and F4 was subsequently elevated when compared to F0 and F1 to 3, although the first year was roughly equivalent. Patients with cirrhosis had a 6% to 50% higher risk of de novo recurrence compared to patients with normal liver. Fibrosis may promote de novo carcinogenesis even without cirrhosis. In conclusion, patients with fibrosis carries a poor oncological prognosis. The oncologic prognosis of HCC can be improved by treatments that inhibit or ameliorate fibrosis. Thank you for your attention.
Thank you very much for a nice presentation. Now this paper is open for discussion. Any questions or comments from the audience? So I think it's quite obvious that advanced fibrosis is correlated with the hepatocellular carcinoma development and progression. Maybe most of the audience knows for a long time. But there are long time discussion whether the fibrosis itself is directly affected on the carcinogenesis or the tumor promotion. Do you have any idea whether it's directly affected the progression of tumor?
Thank you very much. So I think two important mechanisms. So recurrent after curative resection. So one is bad liver function patients was performed the partial resection only. So anatomical resection was the patient who had an anatomical resection was so better prognosis than patients who had a partial resection. So one is surgical procedure is important mechanism for recurrent. So other is, so we analyzed the messenger RNA sequence between fibrosis or non-fibrosis in TCGA cohort. So TGF-beta pathway is activated and other cancer-associated fibrosis factor is so elevated. So I think fibrosis itself is related to culturogenesis by TGF-beta pathway activated. So, but various changes are involved, but we do not yet know which one is critical. So further study is needed. Thank you very much.
Any other question? Please.
So maybe I can hear about the etiologies. So etiologies for this group is only viral hepatitis or the?
No, entire cohort is included non-B C or hepatitis B or hepatitis C.
Okay, so you mentioned that your method is a case matching control study. So it means so etiology is matched to for the F0 patients.
Yes.
Okay. Okay. So this match is so case by case. So etiology is same. Okay. Thank you.
I have one more question. Probably from the another point of the mechanistic view, probably liver fibrosis is closely related to the ability of liver regeneration, and that advanced fibrosis may be due to the poor liver regeneration, and also the regeneration is quite important in the tumor development. And probably you observed that the regenerative response after partial hepatectomy. Is there any comment on the response to the liver regeneration and carcinogenesis?
Thank you very much. So it is a very difficult question. And so I'm sorry, so we don't have data. So further,
sorry, it's a kind of tough question. Maybe, especially in your surgery case, you can observe the response of regeneration after hepatectomy. So that maybe it is somewhat interesting to see the response of regeneration and carcinogenesis. That may give us some insights in the tumor development following partial hepatectomy.
Thank you for your advice.
Thank you very much for your nice presentation. So I'd like to close this presentation. Thank you very much.
Thank you very much.
Okay, from now, unfortunately, number 4 presentation is cancelled. And so I shifted to the number 5 presentation. And number 5 presentation is Dr. Hitoshi Mochizuki from Genome Analysis Center, Yamanashi Prefecture Central Hospital. His title is Big Data Analysis of Fatty Liver, Liver Stiffness, and Liver Cancer Frequency within Cancer Center Hospital. Dr. Mochizuki, please.
Thank you for Chairperson, and I'm afraid I have a lot of discussion time. Using DWH and the HIS data, we'll provide liver stiffness, fat content, and liver cancer frequency within Cancer Center Hospital. Patient underwent FibroScan due to suspected liver disorders were 1,163 individuals, 4,496 times during the 11 years. FibroScan VCT and CAP values were stored in the measuring instrument. All the data were extracted from DWH, including 4 basic patient information, 7 general blood tests, hepatitis virus tests, and calculated index or score amount to 240 billion data. The blood test values closest to the date of the first FibroScan test were used. If FibroScan was performed multiple times, the first and the latest values were used. In this study, hepatitis was classified according to the HBS antigen and HCV antibody. The number of patients with complete paired VCT and CAP data is 1,163. The relationship between HBS antigen and HCV antibody was shown in table below. This is a distribution of the individual initial FibroScan of 101,063 cases from 3,920 examinations. In this study, we separated VCTA values by 12 kilopascal and CAP values by 260 decibel per meter and divided in four zones. Zone 1 is normal liver stiffness and normal liver fat content. Zone 2 is normal stiffness and high fat content. Zone 3 is high stiffness and normal fat content, and Zone 4 is range of both stiffness and fat content. Zone 1 contains 664 patients, 57%. Zone 2, 30%. Zone 3, 25%. And Zone 4, 5%. 60% patients are in the normal range of both stiffness and fat content. Of 1,163 patients on the previous slide, 93 patients, 88.5%, developed HCC. In this scatter plot, light blue plots indicate patients who did not see HCC development. Red plots indicate who developed HCC. HCC developed incidence is 4.1% in Zone 1. Zone 2, 2.6%. 20% in Zone 3. 6.8% in Zone 4. In Zone 3 is showing a high rate of HCC occurrence. The following are the characteristics of each zone. Items in red are above the average and in blue are below the average. Zone 1 has low gamma GPT. Zone 2 has high alcohol intake and high albumin, hemoglobin, and platelet. Zone 3 is elder, has high transaminases and highest transaminases during the course of life, high bilirubin and gamma GPT, and low albumin, hemoglobin, and platelet. Zone 4 is still characterized by poor liver function, but high BMI and high alcohol intake, but no decrease in albumin, hemoglobin, platelet. Next, we looked at how the fibroscan of these patients were changed. Here is a fibroscan change between the first and the last time for 600 and 626 patients who had 2 or more fibroscan tests. The mean observation period from first examination to last is 5 years. The arrows are green for patients whose first position was zone 1. Similarly, from zone 2 are shown in orange, from zone 3 in blue, and from zone 4 in pink. A breakdown of number of people is shown in lower right table. The rows indicate the starting zone, and the columns indicate the final zone. For example, 377 patients departed from zone 1. Patients stayed in zone 1 309. 44 moved to zone 2 with fat gain. 17 moved zone 3, had increased liver stiffness and 7 moved to the zone 4, had increased both liver stiffness and fat contents. Similarly, 68 patients started from zone 2, 151 from zone 3, and 30 from zone 4. Because the number of patients of the previous slide is too large to be easily understood, I choose the patient who started from zone 2, in other words, from fatty liver zone. Half of the patients who started from zone 2 remained in the same zone. 34% moved to zone 1 for fat reduction, and only 6 patients, 9%, had increased liver stiffness and fat reduction. I think this transition from zone 2 to zone 3 is so-called burnout phenomenon. This plot limited to 42 out of 93 patients who developed HCC. Only 2 patients, 4.8%, have moved from zone 2 to zone 3. A similar trend was observed left column HBV positive and HCV negative patient, and the right column HBV negative, HCV positive. The hepatic HCC occurrence incidence and transition is the same pattern. In this cohort, there were a few non-B, non-C cases with 189 patients who underwent fibroscan, 17 of whom developed HCC, 9%. Furthermore, the cancer incidence in zone 3 was similar to the previous result, with 11 of 58 patients, 90%, developed HCC in zone 3, a higher rate than other zones. Analysis cohort of fibroscan transition in non-B, non-C is fewer, 25 cases. Among them, only 2 out of 4 cases moved from zone 2 to zone 3. And only 2 out of all 25 cases total. I'll skip this slide because I don't have time. This study of liver stiffness and fat content by FibroScan and liver cancer frequency shows that carcinogenicity was higher in area of higher liver stiffness and normal fat content. The transition rate is small, that from normal liver stiffness and high fat content area to high stiffness and normal fat content area. Limitation, the number of non-BNOC cases is not sufficient because most of the cohort has hepatitis C and the amount of alcohol intake was not adequately assessed, so the analysis was not performed as NASH. Thank you for your kind attention.
Thank you very much. It's a very excellent presentation. Now open discussion. Yeah, from me is you checking is 5 years to follow up with this case is why you decided to do the 5 year. There is some data before doing 3 years, 1 year. There is some zone changing is occurring.
No, I don't decide 5 years. First examination and the latest examination, the average is 5 years, not a cut of 5 years.
Okay, and the other thing is zone 3 is related to the aging shift. Aging
Yes.
a little bit related to the 5 years are not so affected to the aging, not so much.
Not so relation,
Okay.
but background characteristic is high elderly person.
Other question.
I think a usual process, increasing the fibrosis, zone 2 to zone 4 and zone 3. But you indicate that zone 2 directly to the zone 3. So, but some patients change to the zone 2, zone 4. So, is there any difference or background of the patients like PNP, RES3, SNP, or some kind of the characteristic change exists in those group patients?
I saw the from zone 2, zone 4 to zone 3 is very rare.
Mm-hmm.
Only one case.
Okay.
Only one case. And the characteristic change, not so the characteristic change for 5 years observation.
So zone 2, zone 3, and zone 2 and zone 4, is there any difference of the background of the patients?
No, background difference is not find out.
Okay, thank you.
Professor Matai.
This kind of study can be done anywhere, but if you take a look at this one, as far as you have the fat, maybe you are suppressing the cancer development. How do you think about it? I mean, we cannot prove the burnout phenomenon. In other words, zone 2 has shifting towards zone 3. That case, losing the fat, gaining a fibrosis. So that's maybe you are saying the burnout, but doesn't show that, at least. So maybe you better keep the fatty change in the liver, not to have the cancers.
Okay, very unique analysis. Thank you. Okay,
So Tate Sensei keeps saying the burnout, but where is the evidence?
Yes. I think it's in the future is using to gathering this data. In the next stage is the prediction is to using AI system and so on. Do you have some idea is that to have to predict it is that these future prediction.
It is necessary to correct many patients. This cohort is limited to C or B or some liver dysfunction, but no symptom and healthy people gather, many healthy people gather. It is necessary to correct many healthy people and examine the FibroScan. It is necessary to the accurate result, I think.
Okay, very interesting data. Many people is expected this data. Thank you so much. Okay, now time is coming and we will close this workshop. Thank you very much.
Thank you very much, chairs and lecturers.